Good evening, Pankaj. Good evening. How are you all? I'm fine. Thank you so much, Lokesh. Good evening, everyone. Good evening, Nidhi. Good evening, Aditya. Everyone, good evening. Right. So, guys, am I audible? First thing, second thing, are you all able to listen? Yeah. Am I visible to all of you? And am I audible as well, right? Very good. So, yesterday we were discussing regarding few important things. Yesterday we were discussing regarding few important things over here. Uh, have you revised the previous things? Because see, the two classes PDFs, I've merged them and I've sent it in the group. Have you downloaded it? You got the PDF, right? And I'm telling you, don't share the PDF to anyone. Okay? PDF only share the PDF to those who are attending the class. क्योंकि समझ में नहीं आएगा. That's the reason. You won't understand because the PDF is all about the pictures and all, so it will be difficult for them to understand. Right. Let us wait for 2-3 minutes and then we shall start. Till then, let me share my screen. Good evening, Renu. You guys were there when I was teaching you anatomy, right? Yeah. Yeah, the remaining half will be taught to you in the online itself. Okay. So mostly I don't know if I might come there and teach, or maybe you will have those classes in the morning as we had there. Okay. So right now, any MCA classes going on for you right now there? No classes going on. Skip. Why did you skip? That is what my question is. Why did you skip the lecture? Right now for you, pharmacology, pathology, microbiology, all these are going, all these MCA classes are happening. Who is taking micro? Any idea? Who is taking micro? अच्छा पता है मैं fine. Who is taking pharma? Who is taking pharma there? DK sir will take anatomy, right? DK sir is an Acha Kumar Swami sir. Kumar Swami sir. Okay, fine. So you are telling me and micro I am taking. Uh, he is taking pharma. And what is the other subject that is going on there right now? Patho. Who is taking patho? Patho Krishna sir. Acha Krishna Yadav sir, pathology. Right. I know only one faculty from this. Remaining I don't know at all. Fine. So, Salman Khan sir took micro. If Salman Khan sir has taken micro for you, then why are you not answering the questions which I am asking you in the class? They're all the senior faculties. So you have to be very quick in answering the questions. Right. So let us start discussing the class now. Yesterday, we were discussing regarding the Listeria monocytogenes, if you remember, right? So yesterday we had our discussion with Listeria monocytogenes. So today what we shall discuss? Today what we shall discuss is we shall discuss about Corynebacterium diphtheriae. Okay. So all of you know Corynebacterium diphtheriae causes what? What does Corynebacterium diphtheriae cause? Any idea? Very good. Nidhi, very good. Diphtheria, but not whooping cough. Whooping cough is caused by Bordetella pertussis. Okay. Bordetella pertussis causes whooping cough, or you also call it as 100-day cough, because the cough will last for 100 days naturally. Okay. So that is whooping cough. Okay. Vamshi, not TB. Corynebacterium diphtheriae, the name itself says that it causes diphtheria. Okay. Very good, everyone. So let us discuss all the clinical aspects of Corynebacterium diphtheria right now. Okay. So first important thing in our discussion, is Corynebacterium diphtheriae. Right? Everyone is in the class. Tushar is in the class. Tushar, Mohammed, Faria, Chelsea, Bharatwaj, everyone is there. Krishna Bharatwaj is there. Hasti is there. Sonu, yeah, everyone. Cool. So the first important thing which you need to know, what is the first important thing which you need to know is that this is a gram-positive rod-shaped bacteria. Gram-positive rod-shaped bacteria. And second important thing, tell me, it is a spore forming or non-spore forming? I told you again, there are only two species which are spore forming. What are those two species? Yes, there are only two species which are four. Very good, non-spore forming. Most of you will confuse Clostridia with Corynebacteria. Don't confuse. Clostridia is different, Corynebacteria is different. Okay. So Bacillus and Clostridium species are spore forming, but this is non-spore forming. Non-spore forming bacteria. Non-spore forming bacteria. Third important thing is this is catalase positive. Okay. This is catalase positive. And fourth important thing is this is aerobic organism. Aerobic organism. Nothing new. Nothing new. Yesterday itself, we have discussed these things. If you remember, yesterday itself, we have discussed these things in very much detail yesterday. You remember yesterday's class? Right. So you see, this was the thing we have discussed yesterday. Gram positive, and in gram positive, it is bacilli, and it is an anaerobic organism. Okay, not aerobic, it is anaerobic organism, and it is cat negative. Cat negative in the sense it is catalase negative. Okay, it is what? It is catalase negative. So it is an aerobic organism which is catalase negative. So all of you are clear till here. And next important thing is that, guys, when I was teaching you techniques, what techniques? I was teaching you special staining methods, you remember? In special staining methods in the previous classes, I told you that special structures like flagella, special structures, for example, like metachromatic granules, to stain these, I use a staining called a special staining. And that special staining also is called as what? Albert staining, you remember? Right? Albert staining I use. All of you remember, right? So here, in Corynebacterium diphtheria, we have got granules called as metachromatic granules. I have also discussed, if you remember, that metachromatic granules are rich in phosphate. Yes or no? Metachromatic granules are rich in phosphate, right? Oh, I'm sorry. This is aerobic organism. Thank you for correcting me. So metachromatic granules are rich in phosphate, right? So what are the three different stains you use to look at the metachromatic granules? Anyone? Anyone tell me what are the three important stains you use? Very good, Romita. Ponder stain. You remember I told Pan, Ponder, Albert, and Nessen staining. Very good, Nishoka. Very good. Ponder, Albert, as well as Nesser staining. So these granules are also called as Babe's Ernest granules. Babe's Ernest granules. These are rich in what? These are rich in phosphate. If you look at Corynebacterium diphtheria, right? If you look at the shape of Corynebacterium diphtheria, this is how it looks. Okay. So if you look here very carefully, right? You see, this is how the shape looks. Yes or no? So this is how the shape of Corynebacterium diphtheria looks. Now tell me anyone, what is this kind of shape which I'm drawing right now, guys? What is this kind of shape which I'm very good? This kind of shape over here is called as Chinese letter pattern. Chinese letter appearance, or you can also call it as club shaped bacillus. Chinese letter pattern or club shaped bacillus. So this is another important thing which you need to know. Actually, how many different types of Corynebacterium we have got? So you can remember by the mnemonic GIM, GIM. Okay. So one Corynebacterium diphtheria name is Corynebacterium diphtheriae. Corynebacterium diphtheriae. G stands for gravis. Corynebacterium diphtheriae gravis. Okay. The next important one is Corynebacterium diphtheriae. I stands for intermedius. Intermedius. Third important thing is Corynebacterium diphtheriae. M stands for mitis. How many three types? Gravis, intermedius, and mitis. Okay. Now let us see which of the following is very, very dangerous. The name itself says what is grave? Grave is the final resting place for all of us, right? So that is a dangerous thing. Yes or no? So out of all this, which is the most severe form? The most severe form is gravis. Okay. Now, when I tell MI is mitis. MI is also standing for mild form, right? So this is called as mild severe. Mild severe. Okay. So most severe, mild severe. Then which is moderately severe? That is intermediate. Okay. So intermediate is moderately severe. So there are three different forms of Corynebacterium diphtheria. One is called gravis, one is called intermedius, one is called mitis. Gravis is grave, which is more severe. Intermedius is moderate. Mitis is less severe or mildly severe. I hope all of you understood this thing. This is just the memory part which you need to remember. Now look at the picture which I'm drawing. Okay. Look at the picture which I'm drawing right now. So let us see how this Corynebacterium diphtheria is entering into your body and what does it do basically. Okay. So right. So in this particular picture, all of you know that this is called as your nasopharynx. Nasopharynx, and this is called as your oropharynx. So nasopharynx, oropharynx together join and form laryngopharynx. All of you know this thing, right? Now what I'm telling you is on the wall of the larynx, you have got epithelial cells like this. Okay? Now what I'm telling you is on the back side, if you look at the pharynx wall, you have got tonsils, right? So let us say, these are the two tonsils that are located on the back of your mouth, right? Now what is happening? Just pay attention. Now what I will do is that I will just cut this part and I will draw it down here. Just look here now. This is the wall, and let us say this is one of the tonsil, or let us say one epithelial cell. Okay, one epithelial cell of your pharynx. Now within this epithelial cell over here, you know one important thing, that you have got a structure like this. This is called mRNA. All of you know this is called mRNA, right? I won't go that detailed here. I won't teach you biochemistry. But one thing I'm telling you, this is called mRNA. And attached to the mRNA, you have got another molecule like this. This is called as ribosome. Ribosome has got a smaller subunit, larger subunit, hai na? Attached to ribosome, there is another protein here. There is another protein here. And this protein is called EF2. What does EF2 stand for? EF2 stands for elongation factor 2. Ye dekho, this is your EF2. EF2 stands for elongation factor 2. Okay. What is the use of this elongation factor? What is the use is that within the cell, jitne bhi amino acids say, it will come and attach these amino acids to this mRNA. And this elongation factor will elongate the chain like this. So one, and next amino acid, third, fourth, five, fifth, sixth, in this way, it is elongating the chain. So this process of elongation, of amino acids, finally to form a protein, this is called as ADP ribosylation. What is this process called? ADP ribosylation. So can I tell like this, that ADP ribosylation is because of it is taking the help of elongation factor 2? Can I also tell like this, that if elongation factor 2 is absent, then ADP ribosylation will not occur? Can I also tell like this, if ADP ribosylation is not occurring, then protein synthesis is not happening? Protein synthesis is inhibited. All of you understood now? Everyone? Good morning, Himanshika. After many days, I'm seeing you here, and now you want saved recordings and all. Right. So all of you understood this thing? Everyone? Right. So ADP ribosylation helps in protein synthesis. Helps in what? Helps in protein synthesis. Clear? So in this patient, ADP ribosylation, what will happen here? What will happen here is that, for example, let us say someone is having diphtheria. Okay? Now he accidentally coughed on my face. Okay? So when he coughed on my face, diphtheria ko jo toxin hoga na, that is called as diphtheria toxin. Okay? Diphtheria, don't worry, I'll send it. Okay? Himanshika. So diphtheria toxin, that diphtheria toxin will enter into my upper respiratory tract. है ना? ये देखो, ये है diphtheria toxin. Isn't it same looking like cholera toxin, where A and B subunits are present, right? So now what will happen is that this particular diphtheria toxin is slowly, it is entering into my upper respiratory tract. After entering into my upper respiratory tract, this diphtheria toxin is having two subunits. One is called A subunit, another one is called as B subunit. A or B subunit में which will be dangerous? A subunit is dangerous one. There also the A subunit was dangerous in cholera, if you remember, right? If you remember, that was dangerous. So what will happen is that, see, this is the A subunit here. This is the A subunit, and where is the B subunit? B subunit is waiting outside, right? Now this A subunit, what it will do is that it will damage your elongation factor 2. क्या करेगा ये? This A subunit will completely destroy your elongation factor 2. If elongation factor 2 is destroyed, do you think ADP ribosylation will occur? No. If no ADP ribosylation, do you think protein synthesis will occur? No. If no protein synthesis, then the cell will die. That would lead to cell death. Okay. So overall, what is happening here? There is inhibition of elongation factor 2. This is a very, very important statement. Very, very important statement. So I hope till here all of you understood. Yes or no? Jaldi batao before I go to the diseases. Be fast. Okay. All of you understood, right? Very good. Very good. Very good. Now, next important thing I want to tell you here is, let us see how many different types of diseases you get with the help of this diphtheria. Okay. For example, today the diphtheria toxin entered into my body. So what will happen? Two important things. First, if diphtheria is entering into my nose through the respiratory droplets, I will get a type of diphtheria called as pharyngeal diphtheria. ये वाला जो diphtheria है ना, this is called as pharyngeal diphtheria. For example, let us say there are open cut lesions यहाँ पे. Okay. Now diphtheria toxin fell on these open cut lesions. So if the diphtheria toxin fell on these open cut lesions, the type of diphtheria I will get is called as cutaneous diphtheria. So there are two different types of diphtheria based upon how it is transmitted. For example, if the diphtheria is entering through the respiratory droplets, I get a type of diphtheria that is called as pharyngeal diphtheria. I get a type of diphtheria called as pharyngeal diphtheria. In the same way, if the diphtheria is happening because of what? Because of because of open cut lesions. Open cut lesions, the type of diphtheria I'm going to contract right now is called as cutaneous diphtheria. So two types of diphtheria. One is called as your pharyngeal diphtheria. Another one is called as your cutaneous diphtheria. Clear? So there are two different types of diphtheria. You understood now? Everyone is clear? I'll show you the pictures also right now. Right. All of you look at this. Everyone just concentrate on these pictures right now. See, this diphtheria which you can see over here, this is called as pharyngeal diphtheria. Okay. In pharyngeal diphtheria, the tonsils will be enlarged. When you look at the neck of the patient, this is how the neck of the patient will look. This neck appearance is called as bull neck appearance. What is this? Bull neck appearance. Clear, everyone? What is cutaneous diphtheria? See, this is cutaneous diphtheria. This is your cutaneous diphtheria. Cutaneous diphtheria. Everyone is clear, guys? Everyone is clear, right? Sir, what is this picture? I'll discuss about this picture later on. But अभी तक जो मैंने बोला सब समझ में आ गया ना? Everyone understood? Yes or no? जल्दी. Very good. So if you look at the clinical manifestations matlab what are the diseases which we see over here? The first important, what did I tell you? Let us start from the pharyngeal diphtheria. So what will happen is that this bacteria will enter into your throat, and it will enter into your tonsils, and what it will do is that it will form a membrane on the tonsils. Okay, and that membrane is not a true membrane. Why it is not called as a true membrane? Normally, what is a membrane? Membrane matlab it should be composed of phospholipids, double layer phospholipids, phospholipid bilayer, proteins, glycoproteins, all these things, right? But this membrane is not having all of these things. It is looking like a membrane, but it is not a membrane. So that is why it is called pseudo membrane. Okay, here they go. On the surface of the tonsils, you see a white color pseudo membrane that is formed like this. Okay. So this kind of pharyngitis, you call it as pseudo membranous pharyngitis. What do you call it as? Pseudo membranous pharyngitis. This is called as pseudo membranous pharyngitis. Now, one very important key difference all of you have to remember right now. What is the important key difference? All of you know candida infection. Every one of you know candida, right? Now in the candida also, if I have picture, I'll show it to you. I don't have the picture, I think. Right, I don't have the picture right now, but all of you know that in candida, on the surface of the tongue, you have got a white color plague. All of you know that, right? So what I'm telling you right now is that in candida, that white color plague, whatever is located on the tongue, right? Candida albicans, when you try to scrape it off, very easily it will be removed. Very easily it will be removed. But when it comes to this patient, On the tonsils also, there is a white color membrane you see. Just now I have shown you this picture, you see. On the tonsils, you see a white color membrane there. Now, if you are trying to scrape it off, this will bleed. Okay. This plague will bleed. Keep that thing in mind. Ye dekho. यहाँ पे bleeding है, bleeding of the tonsils, right? So why there is a bleeding of the tonsils? Because you are trying to remove that plague. So what is the difference between Candida albicans and Corynebacterium diphtheria is that in Candida albicans, if you are trying to remove the plague, it does not bleed. But in Corynebacterium diphtheria, if you are trying to remove the plague, it will bleed. That is the only difference which you need to know. Okay. So pseudomembranous colitis, they bleed on removal. Very, very important clinical point. So they will ask you in the question, this point only, it is bleeding on removal, then what it might be. So this will be pseudomembranous pharyngitis. Okay. Whereas Candida do not bleed. Okay. Candida, it do not bleed at all. Right. This is the first important thing. Second important thing is that what is the appearance of the neck I told you? That is called as bull neck appearance. That is your bull neck appearance. Fine. Now, when it comes to microbiology, how do you culture this organism? Obviously, we have discussed the culture methods. In culture methods, what did I tell you? I told you, I have given you a mnemonic. What is this? LODI. You remember that? Lodi. So what is LODI? LO stands here for Loeffler's medium. Loeffler's medium. So in Loeffler's medium, what do you culture? You culture an organism by the name DI, that is diphtheria. Loeffler's medium, you culture an organism by name diphtheria. Clear all of you? Second important thing, I also told you one more thing, that there is another medium that is called as cysteine tellurite agar. Cysteine tellurite agar. You remember this cysteine tellurite agar? So these are the two methods. These are the two agars which we use to cultivate or to culture this bacteria. Remember, the first one is very easy, Lodi, Loeffler's medium diphtheria. Second one is cysteine tellurite agar. So these are the two important things which you need to know. Right? Everyone understood till here? Yes or no? Now we will be going to one very, very, very important test. Very important test. All of you will look at the test and you will answer me the real test when I show it to you. Okay. So this patient, let us say 4 patients are coming to me. They are telling, doctor, we have very severe throat infection. Now, when they're telling we have very severe throat infection, you have to tell them that right now there is a diphtheria infection going on everywhere in the city. So I think you guys might have diphtheria. So let me check for diphtheria. Now, how are you going to check? How are you going to check is that first you explain the patient that, look, I'm going to take an agar plate like this. Okay, I'm going to take an agar plate. After taking an agar plate, I will take 4 of your samples. I will take sample from the throat for all 4 of you. So let us say I have taken the first patient sample. After taking the sample from the first patient, what did I do? I have applied this sample over here. You see, this is patient number 1 sample. I've taken from the throat and I've applied it here. Next, this is patient number 2 sample. This is patient number 3 sample and this is patient number 4 sample. So how many samples I've taken so far? I've taken 1, 2, 3, 4. All the 4 patient samples I've taken. Now what I will do is that I will take a filter paper. All of you are getting it? I will take a filter paper, small filter paper, right? How does that filter paper look, you know? It looks triangular when you get a new Apple device, right? You flip it back and you remove 2 stickers, front and back, right? Exactly, the filter paper also looks like that. Okay, so you take that filter paper out. What you do is that you soak this filter paper in diphtheria antitoxin. Diphtheria will release toxin. For that, I have antitoxin ready. So I will take antitoxin. I will dip that filter paper in the antitoxin. And what I'm going to do is that I am going to put that filter paper in the center like this. You see, I'm putting that filter paper in the center. This filter paper is fully loaded. This filter paper is soaked with diphtheria antitoxin. This filter paper is soaked with diphtheria antitoxin. So I have applied it here. Now, what did I tell you? What did I tell you is that antigens react with antibodies, right? So the toxin reacts with antitoxin. So let us say patient number 1 is really having diphtheria. So when patient number 1 is having diphtheria, within his sample, there might be diphtheria toxin. Within the paper which I kept, there is diphtheria antitoxin. So this diphtheria toxin, diphtheria antitoxin, both of them will react together and they kind of form such lines on 4 corners. These lines which are formed like this are called precipitation lines. If these lines are formed, it means patient number 1 confirmed he is having diphtheria. Okay, so what are these lines called as? These lines are called as precipitation lines. These lines are called as precipitation lines. In the same way, let us say patient number 4 is also having like this diphtheria. Okay, so for him also the precipitation lines are appearing. Patient number 2 and 3, there are no precipitation lines formed, so they don't have diphtheria. So here patient 1, patient 4 are having diphtheria. And patient 2 and patient 3 negative sample. They are negative. You understood this test. If you understood this test, I will show you the real test and you will answer me which patient is having. Everyone tell me you understood it very fast. Fatafat. Very good. Let us look at the real patient sample right now. Right. Here they go. This is the real patient sample. Patient number 1, patient number 1, 2, 3, 4. Okay. So what is this in the center? This is called as filter paper. Filter paper, and this filter paper is soaked in diphtheria antitoxin. Diphtheria antitoxin. And these are the 4 patient samples. Now tell me which patient is having diphtheria over here. Very good, very good, very good, very good. Patient number 1, patient number 4 are positive for diphtheria and these are negative for diphtheria. Very good. These are negative for diphtheria. And you know what is the name of this test called as? Now, very easy to remember the name. यहाँ पे कितने letters दिख रहे हैं आप लोगों को? How many letters can you see? Yes, बताओ. See here. First is I can see this particular letter. ये देखो, I can see this particular letter. What is this letter? This is called as E. Yes or no? So this is E. And I can also see L letter, L. And again on the opposite side also I can see E letter, again E. And if you look here very carefully, you can also see one more letter over here. ये देखो, this letter, K, right? K. So this particular test is called as ELEC test or simply called as gel precipitation test. Okay. ELEC's gel precipitation test. All of you understood this? Yes or no? And second important test I told you, you will have to do cysteine tellurite agar. You remember that? So in cysteine tellurite agar, this is how it looks in cysteine tellurite agar. Okay. So what is this kind of appearance in cysteine tellurite agar? Black colonies are seen. What are these colonies? All these colonies over here are black colonies. Black colonies are seen on cysteine tellurite agar. Everyone is perfectly clear now. You understood it completely. Yes or no? Be very fast, guys. Very good. So now let us do these questions very fastly. Right? Now, another important thing. Yeah, let us do these questions very fastly. Just look here now. 3-year-old male is brought to the ER emergency room with a sore throat and fever. So any complaint of Clostridium, Corynebacterium and diphtheria is what? Sore throat and fever. Examination of the pharynx reveals dark, okay, dark inflammatory exudate. Cystine telluride agar, ये देखो, cystine telluride agar culture produces black iridescent colonies. ठीक है, black iridescent colonies. Iridescent colonies. Microscopic features of the casual most likely include which of the following? बताओ. So first of all, what organism might be this? Patient is having sore throat, patient is having fever, cystine telluride, black color bodies. So this is Corynebacterium diphtheriae, and Corynebacterium diphtheriae will have a phosphate-rich granules. These are called as metachromatic granules. Very, very good. These are called as metachromatic granules. Okay. Which of the following is not a characteristic of diphtheria in an infected person? ये बताओ answer. Which of the following is not a characteristic feature you see in a patient? Very good, very good. Difficulty urinating. Difficulty urinating. We are talking about mouth. We are not talking about the genitals, right? Right. Which portion of diphtheria toxin inhibits protein synthesis? ये भी question पूछा था. What is the portion? Tell me A, B, C, D, E. A part. Very good, Nidhi. Very good. Jacafrey. Very good. Sultan. Very good. So this is part A. Part A. Very good. Razia Sultana. Very good. A 12-year-old. Ye dekho. Now you will answer me this question. 12-year-old male whose family recently emigrated from Eastern Europe presents to the emergency room with a fever of 103.5 degrees centigrade. Swollen neck. कहाँ पे? ये देखो, ये swollen neck है. Okay, difficulty breathing, grayish whitish membranes in the oropharynx. What membranes? Grayish whitish membranes in the oropharynx. कहाँ पे है? ये देखो, grayish whitish membranes in the oropharynx. Okay, so cultures were taken from the pharynx and bacteria were found to be gram-positive rods with metachromatic granules. Metachromatic granules, figure C. ये देखो, ये metachromatic granules है. So this confirms that the patient is having Corynebacterium diphtheria. Now he is asking what the toxin produced by this bacterium has which of the following mechanism of action. Who will tell me the answer? Very good, Nishoka. Sultan, very good. Very good. Ayushi, very good. Very good. So it will inactivate your elongation factor 2. Very, very, very good. Very good. It will inactivate your elongation factor 2. Now I will tell you how the question is asked in FMGE. In FMGE, how they will ask you, I will tell you. Then now you figure out the difference between FMGE and other exams. In FMGE, they will stop the question till here, metachromatic granules, still here, and ask you what is the bacteria. They will give the names of 4 or 5 different bacteria. From that you have to choose. But when it comes to other exams, right, like USMLE and all, they will give you one more point, like the toxin produced by this bacterium as which of the following mechanism of action. This is the only difference. Now, in this question only, you understood both the standards, right? So keep that thing in mind. The next important bacteria which we shall be discussing right now is your Bacillus cereus. Bacillus cereus. And remember one thing, Bacillus cereus is a spore forming or non-spore forming bacteria. Jaldi batao, fatafat. One thing, I have only discussed Corynebacterium diphtheriae, Vraj. Very good. So this is spore forming bacteria. This is spore forming bacteria. Okay. And remember one thing, Bacillus cereus also causes food poisoning. Bacillus cereus causes food poisoning. Okay. So second important point you need to remember is that, you know how Bacillus cereus causes food poisoning? You know what kind of food? Anyone? For example, let us say it is a nice Saturday. All of you are in your flat. Maybe not now. Maybe next year you might go to the flat. I know. When you take a flat next year, Saturday, Sunday is a holiday. So obviously my class won't be on Sunday. So Saturday, happily night, you'll cook the food. And what you'll do, you will, whatever rice you have cooked there, or let us say you have cooked pasta, you have cooked rice and all, you will leave it there. and next day morning you start eating it. Now, next day, how do you heat? How do you eat it? You'll first heat that rice, you'll heat that pasta, and then you eat it. You think that when we heat, the microorganisms will die and I can eat it. But remember one thing: Bacillus cereus is sleeping there. Bacillus cereus is most commonly affecting that kind of foods patients who eat reheated rice and pasta. Okay, so reheated rice or pasta. So reheated rice and pasta, right? So these will be contaminated with this bacteria. So if you eat, that will be well and good. So the next important thing is what kind of hemolysis? Beta hemolysis. And just now you told me that this is also catalase positive. Catalase positive. Okay. So these are some of the properties, right? So you are telling me that this Bacillus cereus is very, very toxic. Yes. Now, what is the toxin that is released by this Bacillus cereus? Actually, this Bacillus cereus releases 3 important toxins. Okay, rather I can tell 4 important toxins, but first let me discuss 3 important toxins. These 3 important toxins are pore-forming toxins. What are these 3 important toxins? These 3 toxins are called as pore-forming toxins. So what are these 3 important pore-forming toxins over here? One is called as hemolysin BL, HBl. HBl matlab hemolysin BL. Okay? अगर hemolysin एक toxin है, तो दूसरा toxin क्या होगा? Non-hemolysin. Yes or no? So the next important toxin is NHE. NHE stands for non-hemolytic enterotoxin. What is this? Non-hemolytic enterotoxin. Third important thing is cytotoxin K. What is this? Cytotoxin K. So these are the 3 important toxins that are released. And what is the mechanism of action? They form pores. That is why they are called as pore-forming toxins. They are called pore-forming toxins. Okay. Now look here how the mechanism will apply here. Let us say this is your gut wall. ये colon, मान लो ये colon है. This is your colon from where? From the colon only, you know, water reabsorption will happen, right? And let us also tell that here you have got the epithelial cells of the colon. So all these are your epithelial cells. So these are all your epithelial cells. Now what I'm telling you is that once you take this Bacillus cereus, this Bacillus cereus will enter into your intestine, and this Bacillus cereus is going to release 3 different types of toxins. Okay, so this is Bacillus cereus releasing 3 different types of toxins. One is called as your HBl toxin. Another one is called as your NHE toxin. Another one is called as your cytotoxin K. And what does these 3 toxins do? These 3 toxins, they make holes in the apical membrane, or they make holes in the luminal side of your enterocytes. These are your enterocytes. All the villi, whatever are there, they are facing the lumen. So you should call this as the luminal side. So you see here, literally they are making holes within this enterocytes. Okay. So when they make holes or when they make pores within these enterocytes, enterocyte ke andar jo pani hai, whatever the water is there, whatever the sodium is there, whatever the potassium is there. So the sodium, potassium, along with sodium water, all of that will be excreted out. Okay. Now tell me, in this type of excretion, is there any blood that is coming out? मैंने कुछ बताया था ऐसा ब्लड वगैरह कुछ है करके? Did I tell anything? Sorry, there is no blood that is sorry, there is no blood that is coming out. So only water with electrolytes are going out. अभी इस diarrhea को क्या बोलते हो आप? Watery diarrhea or bloody diarrhea? What kind of diarrhea is this? This diarrhea is called as watery diarrhea. Very good. This kind of diarrhea is called as watery diarrhea. Everyone understood? Perfectly clear, right? And also one more clinical point I want to tell you here. Normally in the questions, not in the FMGE, normally in questions which are of high end questions, they will also give you the lab values. But anyways, you should remember the lab values for your life. Just few lab values. For example, let us say sodium ले लो. Sodium का lab value होगा 136 to 145 millimole per liter, or in some textbooks it is given milli equivalent per liter. दोनों same है. Okay. For example, if you take potassium is around 3 to 5 millimole per liter or milli equivalent per liter. Okay. ये दोनों lab values याद रखो. All of you remember this. Okay. Right. So when water is lost from the body, will the patient be dehydrated only? Yes or no? So patient will be dehydrated. Patient will be what? Patient will be dehydrated. Clear? Now, another important thing. Tell me how many types of food poisoning, how many types of problems do we have in this patient right now? So right now in this patient, there are two different types. There are two different types of problems we see. One is called as emetic type. One is called as emetic type. क्या होता है emetic type? I will tell you. Another one is called as diarrheal type. Another one is called as diarrheal type. So, for example, I am taking this food. Okay? When I'm taking this food, till now you told me only one important thing: patient will have watery diarrhea. Okay? So it means when I take the food is entering into the stomach and it won't do anything to the stomach. It will do. In the stomach, it is going to release a toxin called, listen carefully. In the stomach, it will release a toxin called as cerulide. Bacillus cereus releases cerulide. Okay, I eat the food exactly after 1 to 5 hours. What is going to happen? This toxin cerulide will make me to vomit a lot. First important thing. Next, ये toxin यहाँ से क्या कहाँ जाएगा? It will go all the way till the colon, and in the colon what it will do? It will release these three toxins: HBl, NHE, cytotoxin K, and there it will cause diarrhea. So when will I get vomiting? After taking the food within 1 to 5 hours. When will I get watery diarrhea? After taking the food after 8 to 18 hours. Obviously, time lagega from the stomach. If it has to go to intestine, release toxins, it would take time 8 to 18 hours. All of you are clear? So overall, you need to remember only two important things: emetic type ek hoga or diarrheal type. What is emetic type? Emetic type in the sense the toxin called as cerulide is released. What is diarrheal type? Diarrheal type in the sense all those three toxins are released. Next, in emetic type, what is the incubation period? 1 to 5 hours. And here it would be around 8 to 18 hours. Okay. So this would lead to vomiting. This would lead to vomiting. And this would lead to watery diarrhea. This would lead to watery diarrhea. All of you are clear with this? Yes or no? Jaldi batao. All of you are clear? Perfectly clear? Right. So this is all about Bacillus cereus, guys. The next important topic we shall be discussing right now is Bacillus anthrax. What is this topic? This is Bacillus anthrax. All of you know anthrax causes what? अभी ये बताओ anthrax causes what? Bacillus anthrax causes what? It causes anthrax. Okay, it causes a disease called as anthrax, which you also call it as wool sortus disease. Very good. Wool sortus disease. Okay, wool sortus disease. Now, in this Bacillus anthrax, if you look at the bacteria, this bacteria is a gram-positive rod-shaped bacteria. Gram-positive rod-shaped bacteria. Rod-shaped bacteria, matlab it looks somewhat like this. Okay, so it's a gram-positive rod-shaped bacteria. Now, if you look at a bacteria here, this is how the bacteria looks normally. But later on, what will happen is that, this is how the bacteria looks. You see the surface of the bacteria, right? How is the capsule or the surface of the bacteria? It is completely even. You know? Most of the bacteria will be like this. But if you look at Bacillus cereus, this is how Bacillus cereus looks. This is how Bacillus cereus looks. Okay. So this kind of appearance you call it as Medusa head appearance. Medusa head appearance. Okay. This kind of appearance you call it as Medusa head appearance. All of you look at this. Isn't it looking? Look at the border there. Circling this bacteria. Isn't it looking like a Medusa head appearance? So this is what? This is your Bacillus anthracis, which is looking like a Medusa head appearance. Medusa head appearance. All of you are clear, right? Right. How many types of diseases this Bacillus anthrax is going to cause? Or Bacillus anthrax causes anthrax, all of you know. How many types of anthrax we have got? Anyone, any idea? How many types of anthrax we have got? We have got three important types of anthrax. We have got three important types of anthrax. First important thing. Let us take there is a anthrax spores here, right? Why spores? Because Bacillus species release spores. Now I am taking the spores inside, right? Now I'm breathing the spores. I'm inhaling these spores inside. Now when I'm breathing, these spores are inhaled inside, right? Now this will all the way enter into my lungs. So this kind of anthrax, I should call it as pulmonary anthrax. What kind of anthrax I should call? Pulmonary anthrax. Second, I have eaten the anthrax spores. These anthrax spores will enter into my lungs or it will enter into my GIT. It will enter into my GIT. This kind of anthrax is called as GI anthrax or gastrointestinal anthrax. Third important thing. Let us say I have got open cut lesions and I pour anthrax into this, right? Now tell me if I get anthrax here, what kind of anthrax should I call it as? Jaldi batao, answer. Anyone? Subcutaneous, nahi, not subcutaneous. Not subcutaneous. Very good, very good, very good. Krishna Bharatwaj, very good. Hasti, very good. It is called as cutaneous anthrax. So the same thing we have studied cutaneous diphtheria, the same thing here. So three important forms. One is, for example, if the patient is inhaling, inhalation of spores, or let us say ingestion of spores, or if the spores are falling on the open cut skin. Okay. So inhalation of spores, this is called as pulmonary anthrax. Right? Ingestion of spores, this is called as GI anthrax. Open cut lesions, you call it as cutaneous anthrax. Cutaneous anthrax. Okay. Now, out of all these three, tell me which is the most common one, most common type of anthrax. Who will tell me which is the most common type of anthrax? GI anthrax is most common. Pulmonary anthrax, no. Cutaneous anthrax is the most common type of anthrax. GI anthrax is the least common type of anthrax. And pulmonary anthrax, you also call it as wool sorter's disease. Wool sorter's disease. What is your wool sorter's disease? Wool sorter's disease is nothing but called as your pulmonary anthrax. Okay. Pulmonary anthrax. Right. Now, next important thing you need to know about this is that what are the risk factors? All of you know the name, what is meant by risk factors? Risk factors. You know what is the risk factor here? The most important risk factor is IV drug abuse. IV drug abuse, that is your heroin. IV drug abuse, that is your heroin. Okay. So this is the most important risk factor which you see. Fine. So tell me how this anthrax will cause a disease. How this anthrax will cause a disease. Whenever you look at the patient of anthrax, this is how the patient of anthrax looks. Okay. You see there is a black color eschar that is formed over here. Right. So this black color eschar, this is called eschar. What is this? ESCHAR. Any black color lesion, you call it as an eschar. The eschar is not a disease. Okay. It is a lesion. So this is a black color eschar that is formed here. This is called as cutaneous anthrax. So here also you see cutaneous anthrax. You see a black color eschar over here. But ye dekho ki, okay, there is black color eschar, but why there is swelling of the eye? Why did the patient have swelling of the eye? Anyone with super brains? Anyone will answer my question. Why is there swelling of the eye? Any ideas, any ideologies? Romita, inflammation. Why inflammation? Why inflammation? Lymph nodes? No, lymph nodes are not involved. This is looking like an edema. Why there is edema in the patient? Just look at the thing which I'm telling you right now. Okay. So first what happens is that, let us take any random cell in your body. Let us take a random cell in your body. On the surface of the cell, you have got a receptor. Okay, you have got a receptor. Now what I'm telling you is that this particular bacteria, whatever is there, this particular bacteria will release a chemical, right? Will release an antigen, and this particular antigen which is released over here, right? So this antigen which is released over here is called as protective antigen. Protective antigen. Protective antigen क्या करेगा? With the help of this protective antigen, this bacteria will go and fix into this. Once it will fix this, now there is a permission for this bacteria. Now there is a permission for this bacteria so that the bacteria can enter inside your cell. Once this bacteria will enter inside your cell, this bacteria in the cell starts releasing two important chemicals. What are those two important chemicals? One is called as EF, another one is called as LF. What is called as EF? EF stands for edema factor. EF stands for edema factor and LF stands for lethal factor. LF stands for lethal factor. Okay. What does this EF do? What does this EF do here? This particular edema factor, let us say this is your blood vessel. This is your blood vessel over here. This is your blood vessel over here. Okay. Now, what does this edema factor do is that this edema factor will cause edema of the blood vessel. It will cause swelling of the blood vessel or vasodilation of the blood vessel. So when there is vasodilation of blood vessel, what will happen? This would lead to dilated blood vessel like this. The blood vessel gets dilated. Okay. So let us say this is the blood vessel wall. Okay. Now slowly when the blood vessel is getting dilated, don't you see there are gaps that are formed between the wall, right? So obviously here also there are some minute gaps that are formed. So when minute gaps that are formed, the blood whatever is here, the fluid whatever is here, this fluid gets filtered out through these gaps and fluid starts accumulating here. And this accumulation whatever is there, that would lead to swelling of the eye. So if I ask you, swelling of the eye is happening because of edema factor or lethal factor, what will you tell? It is happening because of edema factor. Clear all of you? So then what is this lethal factor doing? What is this lethal factor doing is that all of you know within each cell in your body, you have got number of macrophages. Now what this lethal factor will do is that it will go and damage the macrophage. So once the macrophages are damaged, so what will happen? Macrophages are very important cells. So if this macrophage is damaged, this is going to release a lot of cytokines and all. Yes or no? So all the macrophages are damaged. When all the macrophages are damaged, this entire cell itself is damaged. So this entire cell death occurs. So once the cells die in your body, slowly, these cells will become black, necrotic, and finally they will result in this eschar formation. So if I ask you, eschar is formed by what? Eschar is formed by lethal factor. And edema is caused by edema factor. All of you understood, yes or no? Jaldi batao. Perfectly clear. Very good. Very good, very good, very good. So what is the treatment you give? First of all, we'll start with the vaccines over here. We have to give the patient 3 doses of anthrax vaccine. 3 doses of anthrax vaccine. And second important thing is that we need to give drugs like ciprofloxacin and doxycycline. Ciprofloxacin and doxycycline, when you need to, how many days? You need to give this for 60 days, right? For which patients you need to give this? This patient is not having edema. Why this patient is not having edema, Himanshika? All of you look here, surrounding the eschar, do you see a reddish layers which is swollen all the way, right? That is what is called as edema. Okay, necessarily only near the eye you will have edema. No, why usually the eyes swell is that the skin beneath the eyes, there is no subcutaneous fat. Har jagah in your body, everywhere there is subcutaneous fat. But beneath the eyelids, there is no subcutaneous fat. So very easily the fluid will deposit here, causing to swelling of the eyes. Okay, that is the reason why in a patient who is having kidney failure, early morning when you see him up, there are puffy eyes. This is called periorbital edema. Why there is periorbital edema? Because kidneys are failed, so he cannot urinate. So the water will remain within the body. So all this water starts accumulating around the eyes. Okay. Why? Because there is no subcutaneous fat around the eye. Clear all of you? Himanshika, you are clear with this? Very, very good. Very good. So this is the thing. Clear all of you? This is the thing. Okay. How many days you give? 60 days. So from when you have to start? Immediately after the exposure, post-exposure. Post-exposure till 60 days, you need to start giving this patient. Okay. Now you might get a doubt, sir, is this is painful, painless or itchy? How does it feel? Right? How does it feel? बताओ painless होगा कि painful होगा, कैसे होगा? देख के बताओ. Look at this, feel it and tell me how does this look? This black necrotic scar. Painless होगा कि painful होगा? कैसे होगा? Itching? No. This lesion over here is absolutely painless. This is painless. And remember one thing, this eschar within 14 days, it will slough off. Slough off matlab that will come out. The eschar will automatically fall down by 14 days. Okay. Keep this thing in your brains. So next important thing is regarding the question over here. Let us look at this question. 35-year-old patient with no significant past medical history arrives to emergency department with abdominal cramps, nausea, vomiting. Okay. Nausea, vomiting, abdominal cramps. He has no recent travel or chemical exposure. However, 3 other members of his family also arrived concurrently to the ED with abdominal cramps. See, 3 other members of the same family also came with the same complaints. Matlab, you need to think all of them had the same food. So, abdominal cramps, nausea, vomiting bhi hai un logo ko bhi. Now, when asked about the recent activities, they recall that they had a lunch of leftover fried rice and soft boiled eggs about 5 hours earlier. History dekha? How powerful the history is. Lunch of leftover fried rice and soft boiled eggs. You guys eat leftover pizza, right? है ना? खा लो अच्छे से खा लो leftover pizza. The patients are otherwise afebrile, deny any history of diarrhea. Which of the following toxins is most likely? बताओ, which toxin might have caused this GI symptoms? यहाँ पे patient को GI symptoms है ना? Very good. Cerulide. Cerulide is which type? बताओ, cerulide is which type? I think we have discussed this here. Cerulide is which type? Cerulide is emetic type. Very good. Cerulide is emetic type. Okay. Very good. Clear all of you? Everyone is perfectly clear? All of you understood everything which I am teaching now? Give me a second over here. Yeah, if possible, I will try sending this. All of you look at this picture. This is what is called as Candida albicans. This was the Candida albicans which I told you, where you have yellow color scraping on the tongue, right? When you white color thing here, when you scrape this off, this will very easily come. But when you scrape that, that will bleed. Which one? Which one will bleed? Tell me. Which one will bleed? I told you something will bleed. Very good. Very good, Nishoka. That is oral thrush will bleed. Very good. This is also called as oral thrush. Very good. And yesterday, did I tell you that I will show something to you? What was that? Yesterday, I was telling you something and I was also searching for the picture. What was that? What was that yesterday? I told you something, you remember? Yeah, this one. Granulomatosis infantiseptica. You know this? Yesterday, I told you in case of Listeria monocytogenes that the baby will have granulomatosis infantiseptica. You remember that? Bhul gaye? Everything forgot? क्या कुछ तो कुछ बोलो, याद है कि नहीं? एटलीस्ट ये बोलो कि मैंने डिस्कस किया कि नहीं. Very good. Nidhi Jain, very good. So granulomatosis infantiseptica. Okay, granulomatosis infantiseptica. Right. So these are the things which we have discussed yesterday. Clear? So guys, let us cut it short today. And tomorrow we shall have a little bit lengthy class, and we shall, because we have to discuss staphylococcus infections. So from tomorrow onwards, we shall go a little bit fast. Okay. Intentionally, I went so slow these days so that I want all of the new students to connect with me. So I hope you guys got connected with the speed I teach now. Now it will be a little bit faster so that you will understand it perfectly now. Clear, all of you? Everyone is clear, right? Right. So this is all, guys. This is all for today's class. So all of you, goodbye, take care, and I'll send you the PDF also, and recorded lectures also. I'll upload it on the YouTube. Okay. So goodbye, take care, and yeah, love you all.